Hi, everyone. Welcome back to Quality. This is Arjun Venkatesh, your host, where we're going to be exploring quality in emergency care. Today's episode is part of our series that is looking at stroke care, particularly for the ASAP Emergency Quality Network Stroke Initiative. I'm joined today by Corey, who is our co-lead of the ASAP eQual Stroke Initiative, as well as our special guest, Dr. Ejesieme, who is coming to us after years of experience in rural EDs and is now an emergency physician at Methodist Hospital in Dallas. Today's topic is going to be about the intersection of rural healthcare and stroke care, trying to learn about what works well in rural EDs, where are there successes in rural EDs that the rest of the country can learn from, and really helping us identify solutions to help each and everyone within eQual implement their solutions locally. I'm going to kick it off with a question to Dr. Ejesieme about what's the temperature at rural hospitals now around stroke care? Is this something that's on the radar that rural hospitals and rural EDs are thinking about? Or is it more of what I read about in the news where every hospital is afraid of closing and there's new financial stressors? What does stroke care look like today?
So I'm here in Texas, so it's a large state. The rural settings in the South are very different from the rural settings in the North and of East Texas, of course. But I have to agree, I don't think stroke necessarily is the top priority. It is a quality initiative. All hospitals have their quality initiatives that they try to move through. But the biggest concern for rural settings right now, that in my experience, has been staffing and availability of what they have as resources just to do the baseline emergency care that they have post-COVID. I think that took a big hit for rural hospitals, especially in the setting that we have right here, both politically, resource-wise, financially. Some of the Medicaid and Medicare changes that are really big components of how we finance our rural settings. And some of the grants that we were using during COVID also ended quite abruptly, that were used kind of in a multitude of ways. So I don't necessarily know from every admin standpoint, but from a rural setting, the biggest thing that we've been kind of hitting is just resource.
Corey, tell us a little bit about these resources. I know you had a paper recently looking at data from the ASAP eQual network, where we looked at sort of what kind of resources are available in different hospitals, really trying to dig down into what's difference between rural EDs and urban EDs that participate in eQual. What did we learn from that?
So for me, what I could see is that the number of resources that some of these urban and academic centers have is a multitude, not just from in-person neurology, neurosurgical cases, neurosurgical interventions, but also telemedicine. They have a lot of electronic resources that we just we aren't able to tap into necessarily. And I think a lot of what I read and what I hope to push for the future as we mold and blend most of our EHR systems is that we incorporate telehealth, like that we use that in our resources in rural settings, not just specialty specific, but just being able to say, okay, whoever your large cohort transport center is for higher level, be it primary or comprehensive stroke or cardiac, that if they have that resource, that you are able to tap into that, and that financial burden is lifted off of those rural settings, because it's a shared outcome, right? The goal for those resource or receiving hospitals is to get their times down and meet their quality initiatives and provide excellent patient care. And it would only benefit them to have a rural setting or rural hospital, which they receive from quite frequently, have that resource to minimize any gaps in care times, or even just translation of being able to communicate to one another in these settings.
Yeah, I totally agree with that, and the sort of need for and value of telestroke. And that's something I've spent a little bit of time thinking about and trying to understand in my work as well. And I think one of the things that's really interesting about it is actually that some of the places that we expect would benefit the most, and really where we would love to see telestroke because they have the fewest resources and could really benefit from that outside, the sort of additional expertise that telestroke would bring in, are the places that are least likely to have it. That we see telestroke in these like suburban community EDs where they're just doing it in order to get stroke center certification and have their 24/7 neurologist, but we don't see it in the small rural critical access hospital that doesn't have that just doesn't have the resources, and they don't have the stroke patient volume to support it because they maybe get 12 strokes a year. And so, the financial argument for it isn't quite there. And so I wonder sort of how you think that those sites can think about implementing telestroke or strategies like that to bring resources in when their stroke volumes are low like that.
like I think I hinted, is like, instead of it focusing so much so, which I've been very fortunate to work in multiple different volume settings. In a large volume setting, we often have different tele resources, like tele foreign language. So we will have another laptop or phone call or whatever kind of electronic system set up just for translators. Then we'll have, another sample of a telehealth group that we've contracted for neurology, and then another one per se that we've contracted for psychiatry. My hope is in the future that that is blended into one comprehensive unit that can be utilized not just by the larger resource, but our smaller resources, so that those volumes, though they only get 12 or 10 stroke, it can be used for the psych patient, because psychiatry is something that also struggles in rural settings, or it can be used for language barriers, which is often a very, very dire need in those rural settings for languages that often won't come up, like Vietnamese or Spanish, that they just don't have the capability of holding on to that for. I do feel like doing a lot of research on the back end for a lot of the facilities, of knowing what grants and fundings are out there for rural hospitals, is really imperative and important. I don't think we tap into that sometimes as much as we should, because our focus is so spread thin, and our resources, of course, are also spread very thin. But I wholeheartedly think that that's something that would be helpful, or tying in, like I said, some of the largest institutions do have resources available. And if you are able to spread some of that to a bigger catch area, I think the outcomes are much, much more improved, and for the better of the patients in that catch area in which you are receiving those volumes of stroke, cardiac, psych, all those resources. So I think that is one of the things I always encourage ours to just reach out to our transfer. Where are we transferring the most to? Where are our 2 top sites? Let's reach out to them and see if there's resources that we can tap in and borrow from them.
Now tell us, I think there's this easy assumption sometimes people make, or this over assumption people make around the fact that, rural healthcare isn't as good, or the care in a rural hospital doesn't have certain resources. And this blanket statement gets made that quality is lower in the rural hospitals. But what we see in Equal is that we see a lot of success stories come from participants who are in rural EDs. And what you recognize is, just like in any hospital characteristic, be it teaching hospitals or rural hospitals or urban hospitals or big hospitals or small hospitals, there's wide variation. There's high performers and low performers when it comes to stroke quality. What have you seen in rural EDs that's actually gone really well? Like, what are the QI interventions that have worked? What are the things that those rural EDs are able to do? Maybe they're more nimble than others, and really to be the top performers.
What I have seen is being able to communicate not just within their small ED, but also the resources pre-hospital. Because they're rural settings, they're often a tighter niche of communication and a smaller barriers for communication and implementation of programs from pre-hospital into hospital to transfer. And so because of that, I've seen large successes when they start some of these protocols with incorporating their resources outside the hospital, translating them into the hospital, and also into the transfer line or transfer centers. Often they don't have a transfer center, it's just a secretary, but utilizing that whole process from patient's first symptom outside the hospital through the doors of the hospital and then transfer back out. Those have been the most successful, in my opinion. And it's fortunate for them only because the barriers of implementation are far less than at a larger institution.
It's really interesting. And it sounds like a good strategy. I'm curious, you mentioned earlier that, because of sort of the staffing constraints and financial barriers, that it's hard to get QI work to really be a priority in these sites a lot of times. And so even having strategies like you're discussing in hand, I'd love to hear your thoughts on how you motivate those, and how do you sort of get folks behind this kind of work and engaging in the QI for stroke if they're not going for stroke certification, which is sort of the sort of carrot that's used in the bigger sites. How do you do it in the places where there's not that motivator?
So for me, what I found is, one, is it a challenge for your site? Because if it's not, if you have a process and it works and it's not a challenge, you're not going to get a lot of buy-in from everyone else unless you take a step back and you're able to evaluate and say, are we meeting on the metrics for good care? If this was your family member, if this was, a loved one, are we meeting our standard for that person as well as the standard of care across the board by ASAP and AHA? I do have some quarrels when we use the word standard of care, just because standard is so different based on where you are, what your patient is, and what resources you have as maintaining what standard is for your source. So I always try to veer away from that. But as from just the point as we're speaking of using that, if there is some places to improve, which often there is, we use that and say, hey, if we can make this super streamlined, this is not just easier and less forethought for the entire group, but it's cost savings. It makes it almost autopilot and everyone's on the same page. And I'm telling you, in the rural setting, it relieves the stress off the team because everyone understands you use one word and everything kind of goes into action and understands, okay, this is what's coming in, this is what we need. And we even, sometimes would buy some of the additional resources we would need to make that happen, like a toolbox or a little binder or print your own pages, because once you factor that protocol or algorithm in that works for your site to meet those metrics and meet great patient care, outcome is so much, it's streamlined, it's easier, it's more efficient, and it takes the angst of these low volume, high risk cases away from the team. It's just like a relief. It's like a life jacket. And you're like, okay, we've done this. It might've been a year since the last case, but since we already have this in place, I'm just going to follow that book. I pull it out and I know exactly what to do without any thought. And it really does make the team feel confident.
I love that you said both metrics and talked about that frontline engagement, because in Equal, we live and breathe the metrics. In fact, we probably are responsible for making the metrics for a lot of different things in emergency care. And when it comes to stroke care, particularly, the metrics have, been one of those things that you hear a lot of people gripe about, whether it's on social media or at different meetings and things like that. But it's really hard to do quality improvement if you don't have a metric around that. And in the rural setting, the one that I always think about is the door in, door out time metric. And what we hear from a lot of sites is, well, how can I do better at that measure if I can't control whether or not an ambulance is going to get there and pick somebody up? What's your experience been? Have you seen sites who have really figured out ways to crack that metric and get patients to the right care at the right time?
Honest answer or the political answer?
Do both. Do both.
Of course, all of our resources are on the same page about making sure that we provide prompt and adequate patient care. But the reality is, during COVID and post-COVID, it has been very difficult to have the resources to get patients out in an adequate amount of time, even when they're sick, because our acuity, as most clinicians have felt, has gone up quite a bit. And that has to do with not just the low medical literacy rate, low health rate, low ability to get into clinicians for just regular primary care. So we're just seeing a vast increase in our rural settings of not just seeing lower acuity, but higher acuity patients that we just can't handle within our facility. And then topple that with staffing, not just in the hospital, but for EMS crews. That door in, door out time, everyone wants it to happen in less than 2 hours, but that's not always reasonable. Sometimes the transfer time takes 2 hours just to process the paper and get a hospital to accept. I think my most memorable times were during COVID, where you couldn't get a patient out until you had your COVID test back. They wanted to know if that patient was COVID positive or COVID negative before they accepted them into their institution. And those metrics transcended for quite a bit of time to get a patient in and out of those doors. So to be honest with you, I still think some of those barriers are still in place, especially in the rural setting. I think what I have seen is priority. They'll prioritize cases like dissection, stroke, STEMIs, torsion. Some high acuity cases are priority one, but those volumes of priority ones are, like I said, are increasing in my opinion. I haven't seen the data, but from what I see, and then on top of that, not having the staffing that we have to have adequate EMS to make multiple trips, it really makes it difficult to meet that metric.
And so one of the things, that you're talking about is sort of the capacity issues that we're feeling even more acutely right now, it seems like, than we were during COVID. And the idea that stroke can be a priority condition for transfer is very appealing, and I think makes sense. One of the ways that it becomes a priority condition in my experience is if a patient has large vessel occlusion and you compel the transfer because now we're talking about reperfusion in a period of time and it actually is impacting patient outcomes. But that requires doing a CTA. And so how do you sort of reconcile imaging constraints and in-house CT capabilities and this process of sort of optimizing transfer processes? Do you have experience in that, in thinking like, can you just immediately ask for transfer, or are there ways that you can sort of work with your receiving sites to come up with strategies around that?
Excellent point. And yes, the answer is twofold, yes and no. It just depends if it's already in place or you can create something in place for that. Now, we've gone through so many scoring systems. Now, assuming in rural setting, most of the patients walk in, but assuming they come in by EMS, sometimes having that scoring system like a VAN score to help determine who's an LVO candidate can defer them from your institution and send them to a higher level of care to keep from any kind of mounting delay in those patients. So that's in the pre-hospital setting of those arriving by EMS. You can utilize some of the scoring systems to see if they're the best fit for you. That also is really important, whoever your secretary is, or if you're the doc taking the call, to know what questions to ask so that you know that they're appropriate for your site. Second, if they walk in doing an appropriate NIH score or HINTS exam or VAN score right off the bat, having those big scoring systems that we've validated with evidence-based medicine can really help determine, okay, I already know this person's got an LVO and they would benefit from endovascular, and getting those people on the phone as soon as you see them and articulating the verbiage that would push that patient to go to that site. And I think that's what is really important about the communication and making sure that everyone's on the same page. We use the same language, whether we change the protocols or the scoring system, that whatever language that we're going to use as a community of emergency medicine physicians and neurologists and neurointerventionalists, that it's the same. And that we can use that no matter what the setting is to incur, okay, this is the acuity of the patient I have, and the intervention that's needed is what you have and I don't.
So here on Quality, we always let our guests get the last word with our thousands of emergency physicians that participate in our network in the broader emergency medicine community. And so if there's one soapbox you want to share with that world and our community around stroke care or care in rural hospitals, what's that message?
We are all on the same team. When we call, whether it's emergency medicine, internal medicine, family medicine, neurologists, we are all in the same team. We're all taking care of the same patient. Help each other out. If there's a question or if there's a concern, help each other out. Because at the end of the day, we all wake up and we go to this job because we want to help and make things better, not just for the community, but even for ourselves. Some of this is for us. And when we have that insight and really fight for ourselves and our patients, I think the outcomes are amazing. So that's my soapbox, is like, we are all on the same team. Help each other out, communicate, and at the end of the day, just take care of the patient. It'll be okay.
With that, I'm going to thank both Corey and Nnenna for joining us today on Quality D. That was an amazing discussion that covered pretty much everything I could think about with rural emergency care, stroke care, putting it all together. I think that last message of help each other out is not just true when you're going into or out of a shift, but it's probably also true when we think about our bigger emergency medicine community and where our learnings and our improvements in one ED can really help out other EDs that are wrestling with really, really similar problems. And so thank you for tuning in, and we look forward to joining us for the next in the series of the Equal Stroke Initiative.